Welcome to Ask Dr. Mingle, the Q&A series answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle. Good day to all of you tuning in. It's great to see you again. I am Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
We have an excellent lineup of questions today, and remember, you can always send us a question on LinkedIn or YouTube, or you can email it directly to us at hello@minglehealth.com. Okay, let's get started.
I'm ready, Kyle. Bring them on.
Okay, our first question is actually more of an observation. Jason says, I've heard you say that for APP reporting, the 3 CQM measures have the same benchmarks whether they are submitted as ECQMs or MIPS CQMs. And that's not how I'm reading the benchmarks.
Jason, you're absolutely correct, and my apologies for misleading you. There's been some convergence and divergence of benchmarks over the last few years, but for 2023, the ECQM and MIPS CQM benchmarks are different for all 3 submittable APP measures. So let me refresh everyone's memory about this subject in total. We're talking about the APM Performance Pathway, that is the APP, representing the new quality standard for MSSP, that's the Medicare Shared Savings Program, ACOs. To review, there are 6 measures for the APP, 2 administrative claims measures, the CAHPS Experience of Care Survey, treated as one composite measure, and 3 measures submittable by ECQMs or MIPS CQM mechanisms. In addition, for years 2021 through 2024 of the APP, ACOs, that is the MSSP ACOs, can continue to abstract charts and submit performance data for the 10 measures of the web interface, bringing their measure totals to 13. After reporting for the 2024 performance year, the web interface will be sunset and all MSSP ACOs will need to use ECQMs or MIPS CQMs. In overlap years, Medicare applies a favorable quality standard to MSSPs, switching early to the 3 MIPS CQM or ECQMs. In these years, Medicare grants full share of savings or reduced share of losses at a lower total score. I'll explain benchmarks. The 3 current APP CQM measures are number 1, hemoglobin A1C in diabetics, number 134, depression screening, and number 236, control of hypertension. Medicare calculates benchmarks every year for each measure from the data submitted, grouping submitted performance into 10 true deciles of performance, then mathematically adding additional 3 decimal places of discrimination. Yearly, the data is graded against the prior year's benchmarks calculations. It's not real decile or percentile ranking, but it's close. Medicare calculates separate benchmarks for each submission mechanism for each applicable measure. So there's a different benchmark for web interface than for claims submissions, than for administrative claims submissions, MIPS CQMs, and ECQMs. For 2023, for each of the 3 APP measures, a raw performance score submitted as an ECQM would get a higher translated rank score than would the same performance score as a MIPS CQM. That means if you could count on the same performance score from either mechanism, it would always be preferable to submit the ECQM. You'd get a higher comparative decile ranking. All measurements by all mechanisms are faulty to some extent. That's a subject nicely reviewed in a recent JAMA article. All measurement not only reflects true differences in performance, but it also reflects differences in the effectiveness of both your documentation and recovery of data. ECQMs are routinely less accurate than our MIPS CQMs. ECQMs underperform compared to MIPS CQMs on 2 issues. First issue is certification. If any step in your flow of data passes through a process that is uncertified or has lost its certification, that ECQM submission is invalidated and may be rejected. ECQM vendors, usually EHRs, but there's third parties as well, are certified by the Office of the National Coordinator, that is the ONC. Certification grades the ability of the vendor to read and write both QRDA1 and QRDA3 files. It's kind of a process measurement of measurement solutions. MIPS CQM vendors are qualified by CMS. Qualification is an annual review of capabilities and includes a periodic audit of results, more of an outcomes measure applied to measurement solutions. The second problem with ECQMs relates to missing data. Missing data, with rare exceptions, and I can't actually come up with an exception off the top of my head, always reduces calculated performance. ECQM process requirements are rigid. The process is highly sensitive to user compliance with strict documentation standards, and every deviation from standard has a potential to reduce calculated performance. MIPS CQM processes tend to be more flexible. Any reliable data source is usable. Search terms can be broadened and customized. Data can still be missed, and missed data still reduces calculated performance, but the far more flexible measurement is closer to accurate and typically a higher net result. I apologize for misleading you. This year's benchmarks are different for the eCQM and the MIPS CQMs.
Thanks, Jason. Next question today comes from Jane. Jane asks, our compliance department has advised that eCQMs will be the only valid method for APP quality reporting after 2024. What is the evidence that we will still be able to use MIPS CQMs?
Jane, you're not alone. I find it be a common misperception that Medicare will eliminate the MIPS CQM submission option for the APP after the 2024 submission year. I've never heard Medicare say it, but I've heard it frequently from those trying to interpret Medicare communications. I think the misperception comes from the concurrence of messaging about the rules and concrete plans for the APM Performance Pathway, and the simultaneous but unrelated introduction of the concept of digital quality measures. The final rule for 2022 for the quality payment program for Medicare was a big year for the APP. Medicare slowed the transition to the APP and memorialized its plans into rules. By 2025, all MSSP ACOs must stop using the web interface and participate in the APP using eCQMs or MIPS CQMs. In that same final rule for 2022, Medicare introduced the relatively unrelated concept of digital quality measures. Digital quality measures were introduced in the context of issuing a request for comments on the provocative statement that we aim to move to fully digital quality measurement in CMS quality reporting and value-based purchasing programs by 2025. It was not a statement of fact, it was a mission statement. Two things have happened since then. In March of 2022, Medicare released a document entitled Digital Quality Measurement Strategic Roadmap. The document nicely reviews the barriers to and a framework for getting over those barriers and getting to a fully digital measurement system. But it did not place any time frame on that transition, and it could as easily encompass decades than years. The final rule for the quality payment program for 2023 was released in November of 2022. Neither in the published strategy nor in the 2023 rulemaking has any further mention been made of an expected cutover date to fully digital quality measurement. Now, I refer you to the Code of Federal Regulations at Part 425 pertaining to the Medicare Shared Savings Program. It's Subpart F pertaining to the quality performance standards and reporting. If you do an internet search for CFR 425.512, you'll find the standard set in the rules. That states that for performance year 2025 and afterwards, the ACO has to report 3 eCQMs or MIPS CQMs and must report caps for a MIPS survey under the APP. This rule confirms that both MIPS CQMs and eCQMs are expected to continue and to be available after sunset of the web interface option after the 2024 performance year. There's no date set in Medicare rules or even in proposals attached to the rules after which MIPS CQMs will not be applicable to the APP quality reporting. I note that fully digital measurement is not a legislated requirement. For Medicare, this means digital quality measurement is a strategic wish to have rather than a legislated must have functionality. A similar dynamic played out in 2015 when in the final rule for the physician quality reporting system for 2015, Medicare declared that claims measurement option would be discontinued at a to be determined future date. Now, after 8 subsequent rulemaking cycles, that sunset date has not yet materialized. So Medicare can set a date at any time. It just takes a rulemaking cycle to do so, but there really is no evidence that they plan to do this, and I certainly hope they don't. Your functionality with quality reporting will be hurt by moving to full eCQMs.
Great question, Jane. Our next question today comes from Mike. And Mike asks, when identifying all patients for APP quality reporting, is that based on the TINs associated with the ACO or the providers/MPIs associated with the ACO?
Mike, a provider relative to Medicare's quality payment program is a TIN NPI. That is the NPI as it exists in a single TIN. A provider, to Medicare's view, is a different entity as far as quality reporting is concerned in each TIN in which they participate. We'll be looking for all patients of all providers of all participating TINs in the ACO. You don't need to look beyond those participating TINs at other work that the NPI does.
Great. Thank you, Mike. Our next set of questions today comes from Gwen. Gwen's first question is, we have an unusual ACO structure in which we set up new regional practices with new TINs in which we are enrolling participating providers. All ACO patients and only ACO patients will be seen in or by these TIN/MPIs. So 2 questions. How will this structure affect measurement requirements, and how will it affect attribution?
Gwen, that's an interesting application of the model and should help bring some ease and clarity to your project. It makes a lot of sense, and I can see how this qualifies as a distinct business and warrants a distinct TIN and business structure. However, Medicare could consider it to be a loophole, and you may see that loophole closed at some point. Regarding attribution, it won't have much effect. All of your ACO TIN patients will be with the ACO, but not all ACO TIN patients will be attributed to the ACO. It will work a little differently with prospective than with retrospective attribution. In prospective attribution, most of your ACO TIN patients will be attributed to the ACO because the differentiating factor is choice. Patients choose to be in the ACO, and it's not affected much by engagement or comprehensive or comparative visit volumes. There's still some dynamics that patients may withdraw from the ACO, but will still be engaged with a practice and not attributed. With retrospective attribution, plurality of care is the deciding factor. All patients of the ACO practice are eligible to be attributed, but only those getting more primary care from your ACO TIN practice than other practices can be attributed. So more patients will be in the practice than patients are attributed. Regarding quality measurement, because only patients of your ACO will be served by the ACO TINs and NPIs, well, with it, except for those exceptions I listed prior, you will effectively avoid some of the difficulties usually encountered in all patient, all payer quality reporting. It's still a very different experience from web interface reporting. In the web interface, the patients you report on are drawn randomly from the patients attributed and only the patients attributed to your ACO. For the new APP reporting using eCQMs or MIPS CQMs, all patients, attributed or not, need to be included in the denominator, and the numerator status has to be known and reported for at least 70% of them. Great question, Gwen. Thanks.
Yeah, thank you, Gwen. And Gwen has a few more questions. The next question is, Many of our providers are working with 210 practices. One of those 10 practices is working nearly exclusively with our ACO and Medicare covered patients, but they do similar work for other 10s for patients of Medicare and other insurers, but not connected to the ACO. Is there a need to reach out to those other practices to collect data to report on patients of other insurers?
I tried to answer this question in the last set, but I think it bears a little bit of emphasis. An NPI is a TIN NPI to Medicare. They are a different entity with different quality reporting obligations within each TIN, that's tax ID number, in which they work. ACO quality reporting under the APP is specific to the patients seen by all TIN NPIs billed by the TIN participating in the ACO. TINs that don't, that is, tax ID numbers or practices not participating in the ACO, have no bearing on the quality reporting for the ACO. The patients seen by your NPIs in any other TIN practices not participating in your ACO are not relevant to your APP quality submission. Thanks, Gwen.
And Gwen's next question. Some of the TINs in our ACO have a second line of business. They participate in our ACO and they serve their local hospitals as hospitalists. For our APP quality reporting, do we need to include all of the patients from the hospitalist line of business that are not engaged with our ACO?
Great question, Gwen. Very interesting. And the answer is, I'm afraid, an equivocal yes and no. That's not all. That's not bad news, though. You need to report on all eligible patients for each of the three APP measures from all patients of all payers in each of your participating TIN practices. For quality reporting, it doesn't matter if the patients are attributed to the ACO or not. If there are patients eligible for these measures in those TINs, they will need to be reported, subject, of course, to the 70% data completeness requirement. On the other hand, the good news is few, if any, of the hospitalist patients in those practices should have eligibility for any of the APP measures. I took a quick look at the specifications for those measures, and I found no emergency department, hospital inpatient, or hospital outpatient visit codes included in the measure eligibility specs. Our thorough analysis of your billing data will show if any unanticipated coding practices or other billing dynamics extend your reporting liabilities beyond the ACO patient group. Thanks, Gwen. Interesting question.
Two more questions from Gwen today. So Gwen's next question is, as we're still a new MSSP ACO, we are still recruiting practices and working through the requirements and setting up our processes. We're expecting it to be a tough sell to ask our providers for all of their patient data to fulfill the all-patient, all-payer quality reporting requirements. Do you have any advice for us?
Gwen, I feel your pain. But it's likely, I think, that you won't have as big a problem as you expect. Whatever outrage there's been, I've seen directed more at Medicare, not at the health organizations trying to meet Medicare's requirements. This issue first arose in 2017 when 3/4 of providers shifted from PQRS to MIPS. For most of MIPS, all patient, all payer quality reporting has been mandatory since the beginning. I was expecting a big outcry, but it seemed to be no more than a whimper as CMS asserted its rights to get what it wanted. Critics have been somewhat mollified by the observation that Medicare rarely sees the patient-specific data for non-Medicare patients. It only happens in the compliance and audit process. Now, you can kick the can further down the road if you want. You have only a 70% data completeness criteria. You can create a compliance submission without collecting data from the top 30% of your most aggressive objectors. But that creates a double standard in your ACO in which up to 30% of your providers are contributing less than the rest. And the reprieve is only temporary. Medicare will gradually increase the data completeness requirement. You can also use the web interface technique for 2023 and 2024 performance years. That restricts your reporting requirement to Medicare patients attributed to your ACO, but you won't be improving your data flow to help assure accurate measurement of high performance by the 2025 performance year, for which you must deliver all patient, all payer performance metrics that fully meet the quality performance standard. If you don't, you won't collect your share of savings. I recommend a straightforward and factual introduction of the quality reporting requirements to your participants. You have no choice in the matter, and your ACO can't function. It won't collect its shared savings if it doesn't comply with Medicare's all-patient, all-payer reporting requirements. If you need a reference, do an internet search on 42 CFR, that stands for Code of Federal Regulations, 414.1340. That will give you the schedule of data completeness criteria as far as it's laid out in the rules. There are two roles that we at Mingle can play in this. Often a big part of the objection is sharing deep, intimate performance data with local peers that may be partners in the ACO venture, but competitors in other business lines. We serve as an disinterested third party who can collect and process the data, giving organizational access only to the aggregate data, but not to the intimate details. We can also help communicate, as experts in the Medicare rules, the facts of the requirements and options. Good luck, Gwen. Again, I don't think it's going to be as big a problem as you anticipate.
Okay, our final question today is also from Gwen, and her last question is, we expect our providers to be concerned about the security of their data. How does that work?
For our client ACOs and their practices, we at Mingle Health serve as an unbiased third party to hold and handle their data. Data comes electronically to Mingle by secure transmission. It's encrypted in transit and it's encrypted in storage. We automatically strip identifiers from the data, replacing the public identifiers with proprietary anonymous ones. We do all of our storage work and validation on the de-identified data. We re-identify it only on return to the source to assist the practice in data validation and data improvement processes and whatever analysis of gaps in care they want to do with this data. We maintain a highly secure environment with a commitment to SOC 2 level security processes and certifications. We serve under a business associate agreement with your ACO and practices with a HIPAA-defined need for the data access relating to both payment and operations.
Thank you, Gwen, and thank you to everyone else for the excellent questions today. And remember, you can always leave your questions for Dr. Mingle in a comment on LinkedIn or YouTube, or please send us an email at hello@minglehealth.com. And thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle, and thanks to all of you for the great questions. I want to be helpful and I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience, ask your questions. We can be smarter together.